Medurstand. Understanding medicine.
I'm Professor Aziz-ur-Rehman, and this is the second of the series of videos on this fixed ratio combination of basal insulin and GLP receptor agonist. In my first video, I examined how this combo will help those patients who are on 2 or 3 oral agents and not at goal, plus those patients who are already on basal insulin and not at goal, and those patients who are on GLP-1 receptor agonists and not at goal. But I try to prove a point and to make a point that combination is absolutely great because they work through different mechanisms and they have very good effect, complementary action on fasting glucose and postprandial glucose, and the side effect of basal insulin are minimized by adding GLP-1 receptor agonists, particularly hypoglycemia and weight gain. So if that is true, in this video, I'm going to suggest that those who are not on goal with oral agents might as well we consider this combination as first line injectable therapy because they work they work through different mechanism and has got complementary action. So might as well start this combo whenever you consider injectable. So this is insulin degludec-liraglutide combination, the Zoltofy, and early disease journey, clinical evidence. So this is the slide taken from the last video. How about starting with GLP receptor agonist and basal insulin? This is where we ended the earlier video, and I think we're going to take up from here. This is the main topic for this video. Now there are series of trials called dual, and these trials are about IDegLira. So IDegLira, you all know, is a combo of insulin degludec, long-acting insulin, and liraglutide, again long-acting GLP-1 receptor agonist. So in this study, there were total 420 subjects. They were randomized to either receive IDegLira once a day in addition to SGLT2 or other oral anti-diabetic agents, and the number was 210. And the other arm received insulin glargine U100 once a day, and they were also taking SGLT2 inhibitors and other oral anti-diabetic drugs. And again, number was 210. And you know, since we were studying GLP-1, to those who were on DPP-4 inhibitors, they were excluded. Of course, they would mask the effect of GLP-1 receptor agonist. In insulin, this IDegLira, the starting dose were 10 dose steps and the maximum was 50 because 50 dose steps contain 1.8 milligram liraglutide, which is the maximum dose. And insulin glargine starting dose was 10 units, and as you all know, there is no defined upper dose limit of glargine, although to avoid over basalization, once somebody is on 40 or 50 units, we definitely consider moving on to combo. So this is the study design. And inclusion criteria, people more than 18 years, insulin naive. They had not received insulin earlier, and A1C was between 7 and 11, and they were taking SGLT2 inhibitors and other oral anti-diabetic, and BMI was between 20 and 40. And like we in a normal practice, we regulate the dose, and this was the criteria used. At any time, if somebody had blood sugar of fasting sugar of 72 to 90, mean fasting sugar of 3 days, if it fell between 72 and 90, that was considered an adequate control and no further adjustment was done. But if glucose was less than 72 milligram, which was at the verge of hypoglycemia, we would reduce 2 units and two dose steps or units, whatever you call them. And if the fasting sugar was more than 90, we increase by 2 units. And this applied to both arms, whether somebody was on IDegLira or IGlar. So the same formula was used till they were on their goals, and this was a goal fasting glucose. Now you can see with the time, and those who were on combo, this is combo IDegLira, they had achieved better A1C, much better. This was also great. 6.7 is also very good because we need to achieve less than 7%. But with IDegLira, it was even greater. And you know the p-value, very significant p-value. So IDegLira is better than insulin glargine alone when it comes to controlling A1C used in this setting. And Dual 9 also showed that total daily dose over time was less in those who were on the IDegLira because we were monitoring blood glucose, and if you are giving a combo, some glucose lowering will be achieved by GLP-1, so the actual dose of insulin was less. Why we are concerned about the dose of insulin? Because insulin actually causes hypoglycemia and weight gain. So if we can achieve not only similar but better A1C with a lesser dose of insulin, that would mean we can achieve our goal with lesser hypoglycemias and lesser weight gain. And look at this, the p-value again very significant. So you need lesser dose of insulin, significantly less as compared to glargine alone. So at the end of the treatment, approximately 28% of the subjects on IDegLira received the maximum 50 dose steps, of which 83% achieved AB1C, HbA1c of less than 7%. So in 13%, you would need additional therapies, and additional therapy would probably be an injectable branded insulin. And dual 9 again, fasting plasma glucose over time, you can see it was less in IDegLira as compared to glargine alone. Change in body weight was more with insulin glargine as compared to IDegLira. In fact, in IDegLira, if you see, the end point is the same as the starting point. So there was initial decline, but then there was some gain. At the end of the study, about 6 months, there was no weight gain. So IDegLira, a combination of basal insulin and liraglutide, is, you can say, weight neutral, because weight gain of glargine is balanced with weight loss of liraglutide, so you are weight neutral. But with the glargine, like all other insulins, there is weight gain of about 2 kg. And severe or blood glucose confirmed symptomatic hypoglycemia over time was 58% reduction in the rate of hypoglycemia with IDegLira. I think this is very positive finding, because hypoglycemia is the single biggest obstacle in achieving good glucose control. So fewer people would have hypoglycemia. Again, I would like to emphasize this point. Why it is so? Because when you add GLP-1 receptor agonist, then you actually need lesser dose of basal insulin, and it is a lesser dose of basal insulin which is responsible for lesser hypoglycemias. It's not that GLP-1 actually causes lesser hypoglycemia, it is the lesser dose of basal insulin. Further key clinical finding, HbA1c better with IDegLira as compared to insulin glargine as a monotherapy, and weight gain, insulin glargine weight gain, this IDegLira weight neutral, more hypoglycemia with glargine as compared to IDegLira. So summary of this short video: IDegLira offers a convenient and robust first-line injectable therapy. Now, a little background. Once we have to move from oral to injectable therapy, we have to counsel the patient. Patients usually do not like injectable therapies, although we see a lot of potential and lots of benefits. So we need to explain to the patient why injectable therapy is needed. And many times from one injectable, we have to move on to another injectable, and sometimes more than one injectable. So I think if you can start with a combo injectable, perhaps it would serve the patient better and it can continue to control glucose for a longer time. So better A1C and blood glucose, being weight neutral and fewer hypoglycemia if you compared IDegLira with glargine, and also convenient titration because you just have to titrate it like we titrate basal insulin, no further complication, and convenient titration. The maximum dose is 50 dose steps, and most patient would be at goal. So I hope I was able to make a point that patients on oral anti-diabetic agents, 2 or 3, not on uh, goal, can be considered for injectable combo GLP-1 receptor agonist and basal insulin rather than basal insulin, or rather than GLP-1 receptor agonist alone. So with that, I'd like to thank you for watching this video. I am Professor Aziz-ur-Rehman from Medurstand. Please join me to watch my other videos. Thank you very much.